Welcome everyone to this concurrent session room on enabling community engagement and integration to build resilience. My name is Grace Peters and I'm a programs associate at SmileTrain, and I will be moderating the session today. Concurrent sessions are to bring together diverse professionals, experiences, and perspectives, examine new research, evidence, strategies, and practices. We encourage you all to actively participate throughout this session by using the chat bot to ask questions and share your ideas with our presenters. If time allows, a couple of people may be able to use their microphones to participate after each session. In the meantime, you can send questions through the chat box. I am delighted to introduce our speakers, Kenneth Mulanda, joining us from USAID and ICAN, who will kick off this room session. Unfortunately, Robert Moadime, who was supposed to be in that presentation as well, is unfortunately unable to join us. So we have the honor of having Kenneth's full attention. And then followed by Kenneth, we will have Annie Lynn, Humphreys Sonia, Annie Lavins, Maureen Momani, and Bezuhan Birhanu, joining us from Malawi Ministry of Health, UNICEF, UNICEF South Sudan, and UNICEF Ethiopia. And now, without further ado, I will hand it over to Kenneth, who will be presenting Learning and Adapting Resilience-Focused SBC in Uganda. Over to you, Kenneth.
Thank you, Grace. Hello, everyone. Thank you for your time, and thank you for taking time to listen to us this morning, this afternoon. What I want to talk about was basically learning and adapting SBCC for resilience, and also building back a more resilient communities and households in Uganda. ICAN, the project that I'll be talking about, is basically the flagship for USAID for resilience, and it works in 8 districts. With this project, we have a lot of work we do in the area of livelihoods, looking at agriculture, looking at different value chain propositions for the different regions. As I said, there are 8 districts, but those are 3 regions in Uganda. One is basically a Kigezi region, another is a Choli region, and then we also have Karamoja region. And they have diverse attributes in terms of perspectives towards life. So it gives us a good perspective to look on how people respond to resilience in all those 3 regions. So ICAN intends to reach 185 households with women of reproductive age. And basically they try to see how do we do value addition to the partnerships that we work with, and we have those implementing partners and the districts that I've mentioned. I'll take you through the ICAN SBCC approach for resilience planning and at the community level. And basically, it looks at how best can we strengthen systems for communities to think about shocks and think about shocks like COVID and plan for them in advance before they anticipate them and plan for them. So we usually start off with influencer mapping, and that's a process we hold to actually know who should we be engaging and who will give us a leverage when it comes to planning and think about resilience. Then we proceed to have that mobilization. Then we have the assessment. And basically at this point, we're looking at what are the potential risks that we think about, and what are those things we should focus on. And people will tell you, for us, we think if we work on education for our children, it would be a good thing to think about. When we talk about food security, these are the things we should be talking about and saying, let's address the issue of food security in our communities. So we move from that to have the shock analysis, And basically this one looks at what are the potential shocks, and people are able to think about those potential shocks from their perspective. That what are the potential shocks? So, for example, it could be that in our region we have mudslides. There's a potential shock of a mudslide happening in our region. Then people plan how to address that mudslide within that region. Then they proceed to implement, and we have the accountability coming in, and then we review from a resilience perspective what has happened and how we're doing when it comes to our accountability and what we intended to do. So our experience has been one that people usually do not think about taking up the plans that they have set up for resilience, not until a shock has happened. For example, we might talk about hill management, and we keep on saying the importance of having those terraces being done, but not until that shock happens. Then you see that there's a bit of response, that people are able to adopt new behaviors that are coming as a result of that shock of the mudslide that happened, yet they had it already reflected upon in their hill management plan or for resilience. I want to talk about when we had COVID as a shock. Most of the affected things were education, livelihoods was grossly affected. And then we had also to think about new ways of communicating. And those new activities that we had to think about were basically school, because schools were closed to manage the outbreak. So when they closed the schools, what it meant for us in the rural communities, it meant that we'd have a lot of children out of school, and we had to find a way, work with the Ministry of Education to make sure that actually they attend school. So we had distribution of homeschooling materials and building systems around to see that teachers actually able to visit a small number of children within the communities to provide that continuous education support. ICAN is a resilience project, as I mentioned. So one of the things that happened was we had the girls out of school. And as I've mentioned, that when you have shocks, there are opportunities that come through. So the children out of school, the adolescent girls out of school, we had the opportunity of building capacity for them to make and sell masks to the communities where they are. So that's something that came out as part of a shock and a new activity that we had to think about. The other thing that came out was dialogues were not possible because you had to ensure social distancing. We had to see how best do we actually engage and communicate. So one thing that came out was to see that we're able to have radio-based activities happening, but for smaller groups of people. And then we had to introduce SMSs. These are using the phone to send SMSs to key champions who would now go ahead and talk to the people within their catchment area or constituencies. So we had the business service providers, the village team members, and community leaders getting SMSs. Then we also had meetings being replaced by megaphones and home garden visits. So there's a lot of adjustment that happened from what we had previously planned and what we're doing before COVID, and we thought we couldn't do without dialogues in the communities, but we had to adjust. And that adjustment is reflected in the activities that I have mentioned there. I want to proceed to give some conclusions here and some thoughts that we should think about as we go into the discussion. One, COVID is a shock. And it continues to be a shock in so many ways. Losing of a family head. What does it mean for a family? Job loss, employment loss, production without market to consume the consumption, the production that has happened. All those questions keep coming up. And the big question we have is, what should I do and how do I do it? That's a quick question that comes in everyone's mind when you have a shock like COVID. Businesses being closed on a daily, farmers having excess produce without having anywhere to supply their produce. Tourism, which was a big industry for Uganda, in most of those districts where we work, totally went down. So, and the big question is, what do I do and how do I do it? So in terms of thinking from a resilience point of view is how do people respond and how do people recover or rebuild from such a shock? And these are lessons we are seeing, that people are beginning to think about different business opportunities. People are beginning to actually think about what to do with the changing of what they produce in terms of agriculture. So there's a bit of a shift that is happening. And more and more possibly that we learn from a project point of view that as much as possible, we actually come up with these resilience plans, but there should be continuous engagement to get communities to adopt and also recommit to those community resilience plans that you've actually developed. And also one big thing is also looking at the ecosystem as a whole. So if you're to go out and try and address a child or adolescent nutrition or education issues, how best do you actually look at the ecosystem? Who are the influencers? The community leaders, when you move from the community leaders, are you looking at the parents, the head of the household? Are they going to prioritize boy education over girl education because of this shock? So I think the best way we should think comprehensively and say, how do we unlock the child and adolescent potentials with us having an eye to build the enabling environment? Lastly, I want to talk about that after and during shocks like COVID, it's important to foster community and collective commitment and action so that we don't lose that eye and focus to develop the girl child and basically the children as a whole and adolescents as we actually address the shocks that come across. I had some questions that I put across that are still linger in my mind, and basically maybe we could have some thoughts and discussion around these questions. And there were just 4 of them. And one of them was, how did you recommend addressing priorities for children and adolescents amidst a shock like COVID-19? Because it was a learning curve for us, and we kept on thinking about what can we do, and we're still learning because we haven't fully recouped from this shock that has happened like COVID. And we have more shocks to come, like the mudslides I talked about that happen in some of the districts where we work. Then within the COVID context, how can we measure SBC inputs? For example, things like caregiver skills that you actually support, family support that SBC actually looks to address to move that needle. The other one the question I put across was basically, did resilience process seem applicable to other contexts and shocks? Because we talk about resilience all the time, but is it applicable to other contexts and shocks that might be coming our way as we push across as a resilience project? And as partners, I thought we could be able to share some experiences in that area. And lastly, do any of the new or just seem useful for other contexts? Thank you very much. Over to you, Grace.
Thank you, Kenneth. So does anyone have any questions or wanted to answer any of the questions that that Kenneth has up here right now? We can, if you just want to unmute yourself and have any comments or questions, feel free.
Hi, this is Andrew Zappel with the American Society of Hematology. I thought I could just ask a quick question. Thank you so much for the presentation. I'm very interested, as we're thinking about COVID-19 and developing resilience plans and rebuilding or recovery, an issue that we're coming across is oftentimes with COVID, we see it heighten in its, effects, and then it diminishes, it goes away, it's coming back, it's going through some waves. So how are you still, building that resilience and passion and supporting communities to, be forward thinking when there's oftentimes this back and forth that's, causing people to be further concerned and go back into, the concerns over COVID-19, and how are you kind of addressing and handling those sort of back and forth that, many of us are facing throughout the world, and how best you can keep building up that resilience and support for community and interest in resilience despite all these setbacks?
Thank you very much for that question. Just to say that it's a cycle, that even your resilience processes, it's a cycle that you keep on reviewing and you're able to adjust and say, how far have we gone with this one and with this activity that we set out to do, all this response that you set in place, how is it working? So nothing is cast in stone, so you have to keep on adjusting as you go along. And the resilience plans are adjusted on a quarterly basis. So that gives us a bit of room to actually address the new waves that actually happen in regards to COVID-19.
Hi, my name is Joan Littlefield. I'm with AmeriCares. I'm based in the US and work a lot with Asia. And so lockdowns have been an issue in Asia, and having the ability to gather people together to do community problem solving has been a challenge. I'm just wondering, recognizing that COVID-19 was a very specific and idiosyncratic shock, how would your teams have managed to convene the community to do that problem identification and problem solution identification when they aren't able to gather in the same way they normally would?
Thank you, John, for that interesting question. So one thing for sure that in Uganda, radio is still king. It enjoys about 90% listenership. So what we actually did was to have, within our restrictions or government guidelines, they allowed us to have 5 people meet. They allowed meetings of 5 people or gatherings of 5 people. So in this actual sense, we took radio to the people, and we had those 5 people being selected as leaders to basically prioritize key issues that they want to see addressed in terms of resilience. And they would hold that dialogue on radio and to be broadcasted to the larger community. And we had opportunities for call-ins, and people would call in and share their views on what the leaders are saying. So there was a bit of consensus. So if the leaders are talking at that level, other leaders are listening. So there's a ripple effect, but radio is still king in Uganda, and it helps a lot to rely on such platforms that are still available. Thank you very much, John. Yeah.
That's fantastic. Thank you.
Hello, I'm Jessie Linstead from Plan International Finland, and apologies, my line cut out in your presentation, so apologies if this question has been answered already. But in follow-up from Joan's question, how did you find opportunities for two-way feedback? That this seems to be one of the problems with reliance in the COVID context, with as we try to move more towards remote program delivery, that I'm interested in any examples you had of how you got two-way feedback, how you got inputs from communities back into the planning of the program, or how you were able to pick up on any accountability issues that the program experienced.
Thank you very much for that question. So one thing we did, for example, I talked about SMSs being used to reach out to the community leader, community resource persons. And once that was done, we were able to go out and actually have a tracker in our M&E system being created. So within that tracker, we're able to now, at the local level, you're able to have the resource persons actually go out and find out people's feedback in regards to what has been shared as messages. But of course, what it takes away from us and all of us here, it's basically what you miss out was that immediate response that we used to enjoy, that you're able to address issues immediately at the local level. So that was lacking, and it's a learning curve that we are still grappling with. But as much as possible, that tracker system helped a lot. Now, another thing just to highlight was we used text SMSs, and that was a big hiccup that people are not able to read and write largely. So what we're trying out now is the voice SMS, and we're using voices of recognized leaders within those communities, and we're hoping that will give us a bit of feedback. But that two-way feedback is still a challenge that is not immediate. You're actually 2 weeks behind in terms of getting feedback from the community. Thank you.
But that idea about switching to voice messages is great, actually, a really elegant solution. Thank you.
Grace, I don't have access to the chat room at the moment because I have a full screen, just in case the NA.
There's one chat that came through, or one question that came through, asking, can you share more about what the homeschooling material is?
So what the government of Uganda did was to align some packages, some print materials of questions, frequently self-learning materials that they could actually give in terms of the syllabus they're pushing. So those materials, there was a gap in terms of distribution because they're delivered at the district level, but how they move from the district to the village that's where the challenge was. And ICAN was able to work with the districts and with the teachers within the villages to actually receive those materials and support homeschooling. So just to guide a bit, that we have the urban and the rural settings. So the urban settings, people have access to internet and they're able to do online schooling. The rural setting, there's a gap. There's no internet or there's no access to internet. Besides that, not so many people can afford to have a smartphone or a computer to actually attend an online course. So the government grappled a bit with the possibility of using radio, but imagine teaching children on radio, the difficulty it comes with. So there's a lot of challenges going back. So what we opted for was, let's have materials delivered and have a teacher sitting with a smaller group of children within a home setting, and those were candidate classes, so not the whole village, but candidate students. So they were able to have those sessions going on at that level. Thank you. So these are basically text materials that can guide a teacher on how to run those lessons at that level.
So we have another question that just came in. Can you share your thoughts on measuring community engagement, as this is a particularly important PHC and one of the main PHC pillars on empowered people and communities?
One, I think definitely that's a good one, and it's something that we did a beneficiary survey at the end of this financial year, and what we learned was that how low community participation, how low we are performing in regards to community participation, and I think it's something that we need to continuously learn. But my thoughts at the moment, and this is something they're trying to do in our programming, is basically to introduce things like a behavior tracking. These are sort of bridge the gap between the long-term surveys that we conduct maybe at the end of a year. So you have small cohorts that you can actually reach out to and find out their participation in such committee engagements. So if you introduce the behavior tracking or behavior surveillance and tracking system, some of your basically tracking factors that might help with behavior change, but also you're able to track issues around access to information, and you're able to track things like community participation, and these you can do with the small cohorts within the communities where you're working. So this is something we're trying out. I can't speak to it that actually it has worked or not worked, because it's something that I'm just doing now, and we shall learn as we go along. But I'll propose something like that, small qualitative studies, but you have cohorts that you're actually focusing on to pick your learnings in terms of community participation. Thank you.
Thanks, Kenneth. So we have a few more minutes left. If anybody has any last questions before we move on to the next presentation.
Just to say, anyone can share any thoughts around that. I think it would be good for us to learn from someone who has successfully measured community participation engagements here.
So we have another question that just came in. How do you identify the children in the villages? Is it one teacher per small group? Does he or she work full day or a week? And how do you manage children for the whole village while making sure that nobody is left behind?
Thank you very much. One thing I want just to say that these are candidate students. And usually before COVID, they used to go to a local school, which is within their catchment area, not more than 5 kilometers, I think, the longest. So the longest distance. So within that, they know who is who at the community level, and they know the candidates within their setting, with their community. But we work close with the community leaders, the local leaders, and these local leaders are able to pass on the message that candidates have an opportunity to visit so-and-so's home. So within the catchment area, people are able to come together and actually converge the candidates. So it wasn't all children, but it was just the candidates, and then it was one teacher trying to do most of those things with the materials that had been provided. So it's within that framework that we're able to organize and have just the candidates being attended to. Yeah.
Great, thank you so much, Kenneth. For those of you who might have just joined this session, we just heard from Kenneth Mulanda from USAID and ICAN on learning and adapting resilience-focused SBC in Uganda. Now we are going to move on to our next presentation. There I am, and who will hear from Lynn, Humphreys Nsona, Anne Lavins, Maureen Momani, and Bizuhan Birhuan, joining us from Malawi Ministry of Health, UNICEF South Sudan, and UNICEF Ethiopia. I'll pass it over to you, Annie.
Great, thank you. Good morning, good afternoon, everyone. Again, my name is Lynn. I'm with USAID, but I'm joining you this morning in my capacity as the co-chair of the Child Health Task Force's Institutionalizing ICCM subgroup. So just by quick way of introduction, since 2012, ICCM has been recommended as globally as a, for treating pneumonia, diarrhea, and malaria, and targeting hard-to-reach areas and vulnerable populations. And this intervention increases equitable access to life-saving care and referral. And the importance of this, we all know, has been really further enhanced by the COVID-19 pandemic. And since 2012, there has been really considerable progress in the introduction and scale-up of ICCM, but it has been fragmented and undersupported and is reliant on external support. And so in response to these persistent challenges, there was a technical consultation co-hosted by UNICEF and WHO in Ethiopia in July of 2019 with the aim of institutionalizing ICCM within the context of primary healthcare and comprehensive child health programming. So this morning, we wanted to convene this session in order to share the learnings and the recommendations from this technical consultation on the institutionalization of ICCM, and to provide a forum for taking stock of whether and how these recommendations are being implemented at the country level, as well as any barriers to implementation. So we've asked 3 representatives from the country level who represent very different contexts to share their experiences. We also wanted to set the stage for other opportunities to promote these systems-based solutions to institutionalizing ICCM. And so with that, I will turn it over to our first presenter to talk about the meeting itself. So Maureen Momani from the UNICEF headquarters, over to you.
Thank you, Anne. So as Anne has noted, the meeting was held at the brink of the final decade of the SDGs, and it was clear and still is that there is insufficient progress made in reaching the child survival targets. And children, predominantly from the poorest rural households in sub-Saharan Africa, who are often exposed to multiple risks and deprivations, are at highest risk of death, especially from pneumonia, malaria, and diarrhea. So the 14 countries, African countries that were present at the consultative meeting held in mid-2019 were countries with high burdens of under 5 mortality and high burdens of malaria specifically, and all implementing ICCM programs, albeit with challenges that hinder the achievement of the anticipated impact of such programs. And reflecting on the cross-cutting challenges that the country spoke to at that meeting, 3 immediately stood out: that there was lack of national ownership of ICCM that continues to result in suboptimal and uncoordinated investments, which in turn result in community-based frontline workers who are not part of the formal health system, and inadequate essential supplies to deliver these services. So having tabled this, the participants who comprised government officials drawn from across PHC programs, representatives from technical and funding agencies, as well as civil societies, deliberated on what would it take to shift the needle on institutionalizing ICCM. And in the end, agreed to 10 recommendations. And these are worth looking at closely and accessible through the conference report you see there with the link provided. And you will see the areas that the countries pointed to and saying these are the areas that would need focus and attention. I think in line with one of the recommendations, the resources that was around resources allocated for the full package of high quality ICCM need to be included in annual national and sub-national health sector budgets. The ICCM task team has been working to quantify investments in ICCM and community health. And in some settings, funding has dramatically declined or stagnated. And there is a need for us to ensure complementarity of domestic and external funding for community health and comprehensive ICCM, as opposed to reinforcing vertical funding silos. And we will hear our colleagues from country level speak to how they're addressing this recommendation alongside the other 9. They will not be able to go through each one in detail, so they have selected one, and they will be showcasing their country experience and sharing what they have learned, the actions they have undertaken, the challenges, and what they're doing to move this forward. So we'll start off with Malawi. And so over to you, Humphreys. Thank you.
Thank you very much, Maureen. Giving me this opportunity is of great honor. Malawi implements, a mature ICCM program which dates back from 2008. The ministry has set up ICCM basically to champion and increase treatment coverage among under 5 children in hard-to-reach communities, as highlighted by Maureen. What we have been able as a country, looking at the recommendation below the screen that has been shared, expecting MOH leadership. What we've done as ministry, when we set up ICCM in 2008, we were able to convene technical working group meetings. Since then, we have been able to group partners and everybody else who is responsible to support the Ministry of Health efforts in facilitating and implementation of ICCM. And the leadership is provided and guided by the Ministry of Health and the IMCI unit. And with that convening, we are able, as Ministry of Health, to provide mapping so that the partners are able to know where we have indicated gaps requiring their support so that there is no duplication. So we've been able to do partner mapping. In the same way, we have initiated development and use of standardized protocols for the implementation of ICCM in Malawi. But indeed, our trying to provide Ministry of Health nominated individuals, be it training, be it supervision, and indeed any other activities, as well as review meetings. And this guided implementation includes monitoring as well. Despite highlighting these key success factors that have enabled implementation, we still have challenges that are affecting our mature ICCM program in the country. I'm talking about lack of comprehensive partner support. By that, I mean when we have partners, indicating support for a particular location or geographical area that we have mapped. Normally, ICCM has 10 or 8, rather they have 10 components. And all these components, you will have a partner who is only having resources to support only 4 or 5 or indeed part of those components. And then it gives us a lot of tasks to identify other partners who may add up so that we have a 100% implementation framework and indeed saturation for such districts where we have mapped this ICCM implementation. That's one of the key challenges despite our championing ICCM. In addition to the same, another constraint is to do with coordination associated with planning. We have partners working with the Ministry of Health and committing to support the Ministry of Health. What we have learned over the years is that we have resources and indeed letters of support being provided by the Ministry of Health that we can support and provide for this. These are already pre-approved budgets from donor agencies. What we have on the ground is an appeal to absorb what has already been approved elsewhere without an earlier phase of joint planning with the partners or indeed NGOs who intend to support the Ministry of Health efforts, including the complementarity of those activities. We have had to go around and try to attempt engaging partners through our technical working group meeting so that we address issues of a managing partnership approach by ensuring that we get partners to realize that when we indicate that we have 60% gap in this particular district, they need to look for resources for that 60%. But what we have learned is they come up with approved proposals which has a 10% and 20% funding requirement that will only fulfill part of the implementation. And that has created a lot of challenges, and our mature ICCM implementation program is still suffering setbacks due to such arrangement. We are learning a lot from such shortfalls, ranging from lack of coordination, which basically is a threat, as highlighted by Maureen, that as we are pushing forward towards community-based primary health care goal achievements, as well as universal health coverage, institutionalization cannot take into effect if the support and indeed the mapped partners that we assign to work in those districts that do not saturate or indeed satisfy or complement government efforts fully. So coordination is one issue that we intend moving forward to facilitate in a coordinated way with all partners, including global donors who are working with us, because we have had situations where funding would come to a different program, and then ICCM voice for that particular program is not necessarily being heard. Rather, the ICCM voice is being represented by another program because resources were channeled through that particular program. We faced challenges, but being represented when you can voice out some of these challenges has created a lot of problems in our implementation. So what we wish moving forward is basically looking at program support that should allow engagement of government starting from obtaining of letters of support from Ministry of Health. They should go beyond just indicating availability of support. Rather, partners should indicate beyond availability of support by showing how that available support is aimed at addressing the country needs or country requirements. Those are the expectations that we wish, and indeed increased funding, financing that will automatically provide for intensified and consistent availability of medicines, supervision, monitoring for our program is very essential. Because ICCM, without consistent, interactive, engagement processes may not, remain active at community level because there are so many competing challenges that require, everybody's attention. If we have to realize institutionalized ICCM at that level, as we are working towards universal health coverage within the community-based primary health care, platform for our government, but also globally towards 2030. Thank you, Maureen.
Thank you, Maureen, and thank you, Anne. Greeting from Ethiopia. Good morning and good afternoon all over the world. So thank you very much for giving me the opportunity to share the experience of Ethiopia, how the country is fully incorporating ICCM and the national policy, country health sector development plan, and etc. So it's also one of, the recommendation has been already introduced by the Maureen and Anne, and as the first speaker. It's one of the 10 recommendation among the meeting we had in Addis about the institutionalization of ICCM. So from the experience of Ethiopia, so we have different demonstration how the country is fully incorporating ICCM at a national level. So one of the main demonstration is that the inclusion of ICCM in the health and at health post service delivery and the essential health service package of Ethiopia. So this package actually is defining the essential health service package for the country and also identify priorities for health intervention. And therefore, this is one of the critical strategy for the country. That's why ICCM has been already embedded, and also ICCM is going to be provided in the health post as free service. And, the government decided even to give a free service as, the major service delivery point. As a second demonstration is that, most of you might know that the health extension program is one of the national flagship program. And again, to revitalize the universal health coverage through the primary health care, a roadmap for optimizing for the health extension program has been revised and launched recently. It's about a 15 years country program. And again, in this flagship program, and the specific to the child health, the diagnosis and treatment of childhoodness at a community level is defined by as ICCM. So it has been also given a huge attention as as a main flagship program for the country. And again, we look at also the national strategy for newborn and child health in the country. In this overarching document, again, the community-based intervention, like equipping health extension worker on the basic preventive and curative service, including ICCM and also community-based newborn care, has been also included in the national strategy for newborn child health. And again, this also emphasized to ensure the effective universal health coverage of high-impact intervention, giving attention on the poorest marginalized section of the population and region that requires equitable development. So you can imagine how the government is decided to incorporate ICCM in the major high-level document. And again, this newborn and child survival strategy is being currently reviewed, and also ICCM is given huge attention in this document. When we deep dive to the actual ICCM implementation, so there is a specific guideline that geared the national level ICCM implementation in the country, where every developing partners, the government has already aligned. And this guideline is, we call it the National Implementation Guideline for Integrated Community Management for Newborn and Childhood Illness, where it guides the adherence of ICCM at a national level. So this document is already addressing the equitable continuous access, quality of care, adequate and sustainable availability of essential ICCM supplies and commodities, and also the issue of sustainability and also ownership and sustainability of program, and also including the monitoring, evaluation, and learning system at all levels. So this is really a great document where everyone is adhering to implement at all levels. So to look at some details in terms of ICCM implementation in Ethiopia. So it's ICCM in Ethiopia is a very comprehensive and integrated service package, which includes community-based newborn care, including the very severe disease for sick young infant, and also the pneumonia, diarrhea, fever, malnutrition, childhood tuberculosis, HIV/AIDS, and other common diseases for sick child. So it's harmonized and integrated approach. And again, with the context of integration, so that, the health access worker have also an integrated job aid, which includes a chart booklet, training modules, registers, and also supervisory tools. So everything is integrated in that tool. And again, the child health commodities are also included in the integrated pharmaceutical logistics system, so that the ministry is leading for the forecasting, the procurement, the distribution of essential child health, and also ICM commodities at all levels. So already the essential supply is already integrated in the IPL list. And again, if you also look at the angle of the monitoring and evaluation, so there is a defined HMIS indicator where it has been already included in the national HMIS guideline. And again, data information is collected through district health information system regularly. So these are, some of the insights regarding to the implementation of ICM. So to mention some of the best practice in the country, why ICM is, how incorporates at the country level at such a level. So one is the ministry leadership, the government leadership is one of the key milestones for achieving all these results. So the ministry leadership is very critical, and also ministry is believed that ICM is a equity-focused strategy, and also that providing timely and effective treatment for common childhood illness in the country, because majority of the population are living in rural area. And again, this also facilitating the referral link between the health support, the community to the primary health care, primary hospital, and also health centers. And again, the next one is
we need to transition to our speaker from South Sudan, who has a very hard stop. And so I think in the question and answer time, hopefully we can get back to some of these topics on Ethiopia. Thank you so much, and I'm so sorry.
Thank you.
Hi, everyone. An apology. We're in South Sudan, we have a curfew, and I need to leave in 10 minutes. This is why, so very sorry about this. But and just not to make it much longer. So in South Sudan, so I'll briefly present a bit of our experience in terms of supervision and how it's very important that it's incorporated into the national health policies, and that it's embedded in all the institutionalization of the community health system. Just in South Sudan, briefly on the context, and we're talking about ICCM being too much donor-driven, etc. In 2017, the South Sudan Ministry of Health drafted the draft line for their own national community health system, which they call Boma Health Initiative. So it's the equivalent of ICCM. Although they, by themselves, it was to be commended. This was very an ownership effort. But you can understand that they did that by themselves, and there was a lot of bottlenecks. So in 2017, the guidelines, national guidelines were drafted. Unfortunately, not much moved on that until 2019. UNICEF took a lot of leadership in making then the BHI operational, including by developing an implementation plan. And the reason I'm saying that, because in this implementation plan, there was a whole section on how supervision should be done. We all know that supervision is very critical to ensure quality of care, and that actually the activities are taking place. So there was an implementation plan, there was some guidance with the role of the Boma health worker supervisor, at which level they should be, what they should look at in terms of supervision, but it remained obviously a general guidelines. Then towards the end of 2019, I'm very summarizing because I'm aware of time. Towards the end of 2019, the effective rollout took place in areas where there was no community health. We trained Boma health workers in areas where there was ICCM at the request of the National Ministry of Health. Those community health workers had to transition into BHI. There was slight modification in the package, etc. So just to explain you the context so you understand where it comes from. So we had some kind of national documented policy level talking about supervision. We trained them from October, November until March, April, even May this year, last year, 2020, there was a lot of training going on. And from the end of last year, we started supervising UNICEF together with our implementing partners, just to flag that in South Sudan, any delivery of services is outsourced to NGO because the Minister of Health is not able to implement that by themselves. So there's most often an implementing partners. So we did a lot of supervision. We came up with a lot of findings. At the same time, at national level, because UNICEF ourselves, we implement with our implementing partner in 2 states of South Sudan, and have pool fund with a pool of funds from other donors in the other states. So there was a national evaluation, so not only for UNICEF supported program, and some challenges in both sides, whatever the place were identified, some of which I'm going to highlight now very quickly again. Sorry for the speed. One of the main challenges that was found in this evaluation is the lack of harmonization. So a lot of Boma health worker supervisor do work, but the supervision tools are not harmonized. The training was not sometimes harmonized. The frequency of supervision or the supply chain procedures, a lot of things are done a little bit like implementing partners things they should do. Another challenge that was identified was very much that the supervisor had to cover large geographic areas, especially in the rainy season in South Sudan. And that means that especially in the rainy season, those supervision could not take place. There were also a lot of in areas insecurity, preventing the Boma health workers performing those supervision. So a lot of contextual challenges there. Then also in this evaluation about supervision that was on a national level, through interviews, etc., the supervisors, including the Boma health workers, complain about remuneration. So the motivation was not there. And we have to know that in South Sudan, like most probably in many countries, those community health workers, they do their activities as a second activities. They have income generating activities on their own. They are farmers, and they don't have all the time they should have to do their activities. So, and it's the same for the supervisors. It was also noted in our supervision and as well as the national evaluation that the skills of the supervisor were in many cases lacking. You know that the level of education in South Sudan is very low, and the training that was done for the supervisor. So I explained you the beginning with the context so that you understand that there was some information and some system in place for supervision. However, because we were pushed by the ministry to roll out this very quickly, maybe the skills for supervisor were not strengthened enough, and the training did not address enough the skills that they needed to have to do supervision. So, and there were some tools there, but maybe there was not enough training. So when we went on supervision, we noticed that in a lot of places, supervisors did not understand what they were supposed to do, what they were supposed to supervise, and there was not a specific training manual for them about supervisory skills. So for all the reasons I mentioned, but also, you know, lack of time, second, other activities, challenges in access, flooding, etc., the supervision we're not carrying out in this first year of the rollout of the BHI, we're not being rolled out systematically by the Boma health workers. Also, we mentioned about the tools. So not all the supervisors used the tools that was available. Some of them used no tools, no checklist. Some of them used the checklist that was available, but found it a bit long and complicated. That will need some revision. The evaluation also found out that there was a lot of stock out of drugs, questioning the somebody else, another panelist mentioned the distribution system, the supply chain system, and the importance embedded in the health system. So that's an issue we're facing too in South Sudan. So based on the finding of all our supervision this year on this evaluation, there's been a decision to try to work more at national level on harmonization of tools and system and the way supervision is done by having a supervision policy and guidelines, concrete, more operation guidelines. As I said, we had something, but it was maybe not enough, not strong enough to guide everyone. So we need more supervision guidelines and also more tools that are maybe more simple and in addition to the tools. So we had some tools, but it seems they're not sufficient. We need more tools to really concretely guide the supervisors on all the different activities, whether it is clinical coaching, observation of treatment, or resolution of problems or checking of equipment, checking of drugs, etc. All those need to be better fleshed out, and we need to have more tools that are simpler for people to use. So this is a bit like, I wanted to share this experience we have with supervision and how we've tried to analyze the weaknesses in the program and the areas of improvement to improve the supervision, but in a way that is more systematic and that is embedded in policy, with harmonized, standardized tools, policy, bringing on board all stakeholders in the technical working group. And apologies for being so quick, given time constraints. Over.
Thanks so much to all our speakers. I want to transition back to Maureen just to give some announcements about opportunities to continue this conversation, since I'm not sure if we'll be allowed to stay in the room for Q&A. Grace, if you could let us know about that.
I think we just have a few minutes. We can go over maybe 3 or 4 minutes, and then I can do closing statements, if that's all right. So maybe get to 1 or 2 questions, or you can just wrap it up.
I'll pass it to you, Maureen, and if there's any questions, feel free to come off mute or put it in the chat so we can address those quickly in the remaining minutes.
Thank you. Colleagues, it's definitely impossible for us to delve deep and address all issues or lessons here, given the short time. But I think suffice to say, there is an opportunity to continue this dialogue around institutionalizing community health and delve into the recommendations, build upon the recommendations from the previous meetings and the actions at country level in the upcoming Institutionalizing Community Health Conference planned for the 29th March to 1st of April, aimed at bridging the SDG gap to accelerated PHC at community level. So I'll leave it here. More to come. Look out for it, and you'll be hearing from us. Over to you, Anne.
Thank you so much, Maureen. Are there any questions from the group? I know we have just such limited time. I've just shared a link in the chat, also for the Child Health Task Force Institutionalizing ICCM subgroup, where which is an ongoing forum for discussing these issues. I'm sure folks are trying to get to other sessions as well. So thank you for their time, and thank you for allowing our speakers to be able to have the time to really share the experiences from their countries. There's a question about further recommendations for areas of further research on ICCM implementation. Does anyone have any country-specific examples from that they want to share? Or Maureen, from a global perspective?
I think one that is worth highlighting here that has been is definitely an area, an emerging area of interest, is how do we expand the service package beyond Survive, or even within Survive, looking at the non-communicable diseases, injuries that we know are also an increase in the cause of morbidity and mortality among children. And so how do we make a more comprehensive package of services to be delivered at community level while still keeping pneumonia, diarrhea, malaria addressed, is one of the areas that we're looking at, and looking at operational research around this and lessons from countries. So how do we redesign child health to address these needs more comprehensively is one of the areas worth highlighting, and a global discourse happening around this. Over.
Thanks. And I can highlight too from the USAID PMI perspective that we're going to be conducting some operational research that's looking at how to increase utilization of ICCM services and through various models that strengthen the full system and strengthen implementation through supporting community health workers to be proactive in their service provision. And so that's something that we're looking at on the PMI side as well. Humphreys, I saw that you were off mute. Did you have an experience to share or a research topic to share from the Malawi perspective? Okay, well, I know we need to wrap up. So I'm just gonna put my email in the chat here. And if there are further questions for the presenters, you can direct them to me, and I will pass them on to the presenters so that we can keep these conversations going. Thank you all for your attending.
Thank you so much, Annie. I just want to thank our presenters and all our participants once again for a rich and insightful discussion on enabling community engagement and integration to build resilience. As we conclude our session, please head back to the conference website to join the marketplace sessions, and I hope you all enjoy the rest of the conference. Thank you so much.